5, right? 55 or more out of 75. And if you mention the name and the number of your cranial nerves that you're testing as you go, it's extra credit. Also, don't forget you are explaining what you're doing as you go. If you forget something, it's okay. You could just say, oh, I would also check this. Or if we are saying, is there anything else you might check in the abdomen? Don't say no, because it probably means that there's something that you forgot to check. Okay? So think through it in your brain. Practice, 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 and you guys will be great. All right. Ready?
Yep.
Okay, first I'm going to come in. I'm going to wash my hands. Okay? And I'm going to introduce myself. I'm going to say, hi, I'm Rachel. I'm the nurse taking care of you today.
Hi, Rachel.
I'm just going to look over you and do a quick assessment, okay?
Mm-hmm.
And then I want to check, verify my patient's identification, right? So I'm going to look at his armband, because that's what he has. I'm going to say, can you tell me your name?
Gabriel.
All right, Gabriel, can you tell me your last name?
Vera.
And your date of birth?
11/16/91.
All right, because remember we do 2 forms of identification, and we have to verify that with the patient. Okay, and then I'm going to don my personal protective equipment, which is gloves. And really, if your skin's intact and their skin's intact, gloves for just a basic assessment aren't 100% necessary. I mean, if they are weeping or bleeding or sweating or your skin's not intact, then definitely. But you're washing your hands before and you're washing your hands after. So it's okay to touch your patient without gloves. That's what I'm getting at. Okay, so I put on my gloves and I say, all right, Gabriel, do you have any allergies?
I don't.
Okay, and I want to make sure that I have everything I need for my assessment. You will have it here, but just be aware of what the equipment is that is on the table, okay? Stethoscope, you'll all bring your own. We'll have the ophthalmoscope, otoscope, everything to test for your cranial nerves, cotton ball, Snellen chart, and your reflex hammer, okay? So first I want to do my general survey of Gabriel. I'm making sure that I'm looking at his posture, I'm looking at his affect, I'm looking to see that he is awake, he's alert. He is at least oriented to self because I already checked that. And I'm going to do a Romberg's test. I'm going to ask Gabriel to stand up. And I'm going to ask him to face the middle. Put your feet together, please. And I'm going to ask him to close his eyes. He's not waving side to side. He is able to maintain his balance. And I'm going to ask him to walk heel to toe down about 10 steps and then turn around, please.
My eyes open and closed.
You can open your eyes.
How many steps then?
Yeah, you can do 10. And then when you turn around, just walk back to me normal. I'm watching his gait and noting that he is not ataxic or waving side to side, and he's not limping. Go ahead and sit down. So we can tell that he is appropriate for age developmentally. He's well nourished. He's awake. He's alert. He is generally in good shape. So general survey is complete. Next, I'm going to inspect and palpate his head. Okay, I'm looking at his hair, I'm noting the distribution, I'm looking for any lumps or lesions, and any lice, which he has a history of, so we have our gloves on. No, just okay, so we're looking at we're looking for his lice. Now, and we're going to come down, and at this time I'm going to inspect and palpate the external ear, okay? That is obviously under your ear section, but we've already done it, okay? I'm also going to start palpating his lymph nodes. We have our post-auricular, our pre-auricular, our jugulo-gastric, mandibular, submandibular, submental. We're coming down the anterior cervical chain and doing our supraclavicular. Did I already check the occipital?
No.
I'm not sure. Okay. So while I'm doing that, I'm also inspecting facial symmetry. I'm looking at his nose for symmetry and his mouth. Go ahead and smile for me. Jeez, very nice. All right, so go ahead and say, blow out your nose. Checking nasal patency. And when I get my otoscope out, I'll go ahead and look at his And I also want to palpate his sinuses. Any pain? We would expect that they would not be painful, right? Go ahead and, I'm checking his temporal mandibular joint. Go ahead and open and close. And protrude your chin out.
Right.
Put your jaw out. Bottom jaw, good. All right, perfect. There's no crepitus or anything of that nature, and he has adequate musculature associated with that. He is very well matured. So, next I'm going to look for his head range of motion. Go ahead and turn to the left and the right. And go ahead and shrug your push up against my hand. And against this hand. Shrug your shoulders against mine. Okay. So we just did our spinous cranial nerve, our spinal cranial nerve. And with the face, we are doing, which is cranial nerve 11. And then we want him to raise his eyebrows, puff your cheeks, smile, show me your teeth. And we just did our cranial nerve, everything symmetrical. We just did our cranial nerve 7, which is our facial. And then we want to palpate, which you guys didn't practice this much, the temporal artery, which you can feel it just right there. You can palpate both of these at the same time. And they are a 2+. You want to be able to feel 2+ pulses. They're not bounding, they're normal. Okay. Yes, I'm using my cheat sheet. I don't want to miss anything for you guys. And then the temporomandibular joint and the strength, that was our cranial nerve 5, which is our trigeminal. And we palpated the maxilla and frontal sinuses. We expected that they weren't painful, and obviously no crepitus, no extra air. So then we're moving on to our eyes. We want to look at the optic nerve, which is our number 2 cranial nerve. And we would do that with our Snellen chart, which you guys could say, at this time I would get my patient up and walk over to the Snellen chart, or this would be on your table, and you would just ask him to cover one eye and read line. This one?
63925.
Okay, go ahead and switch. Okay. And read this one.
8745.
Okay, perfect. This is obviously not our real Snellen chart, but it's close enough. So then we want to look, we just did our optic nerve, and now we want to do our ocular motor, and we want to do our abducens and our trochlear. So go ahead and follow my finger with your eyes only. Then we want to make sure it gets that middle gaze. Perfect. And then we want to check for equal pupils, right? That they react and that they're accommodated, and they accommodate, and that is referred to as per la. Remember, if you don't check accommodation, you would not say per la. We want to come in from the outside. Well, that's an interesting setting on my, that was like the stripe. Go ahead and look straight ahead. Beautiful. And at this time, I'm going to ask him to look over my shoulder at the wall. Over my shoulder at the wall. Are you looking over my shoulder?
Yeah.
Okay, now look close up. And you should see a change, right, in the pupil size. It's hard to see in a bright room because the light doesn't make really much of a difference. And next, obviously, during our inspection of the eye, you would be looking at the sclera, the conjunctiva, make sure there's no icterus, and that there's no extreme redness or drainage coming from the eye. So we already inspected the external ear, the position, they're equal, they're symmetric, and they're not low set. They're within a normal expectation of an ear. And we inspected we want to inspect the internal ear at this time. You'll have 2 of these hopefully. If not, I'm not going to know, honestly, if you actually visualize the tympanic membrane at this point. Don't jam it in their ear and take up time trying to find the tympanic membrane. But I do want you to describe it to me. I would pull the pen up and back, and look in, and I see a nice reflective gray non-bulging, non-red tympanic membrane. You might not get the light reflection. Then, at that time, you can switch or use the same one if you really want to. And go ahead and look up the nair and make sure that there's no rhinitis or inflammation, redness, or drainage that we don't want to see. Then we want to make sure that he can hear. So I'm going to perform the whisper test, checking for my acoustic cranial nerve. That's our number 8, right? Yeah, 8. Very good. Our vestibular, cochlear, or our acoustic. And I'm going to whisper 3 words behind his ear, behind his head, and see if he can repeat them.
5, 7, 9.
Okay, so he passed the hearing test. Next, we're going to move on to our, we did our nasal patency, but now can he smell? Could you go ahead and close your eyes, Mr. Gabriel?
Mm-hmm.
Tell me what you smell.
Coffee.
Okay. Perfect, he passed. All right, you can open your eyes, and I'm going to inspect the inside of his mouth. Go ahead and open your mouth, Gabriel. I'm looking inside, looking at the cheeks, looking at the teeth, the dentition. I'm looking at his uvula. Say ah. And stick out your tongue, which you already are doing very nicely. And that is going to be our cranial nerves 9 and 10, our glossopharyngeal and our vagus, and our hypoglossal. You have to gag him a little bit. Gag. Shush up. Stick out your tongue. I'm really going to gag you now. And he didn't gag, but we saw that raised in the back. Okay. The gag reflex would be your vagal. So then, I'm moving out, and I already did the neck and shoulders, right? I palpated the neck and the nose. We're moving down the neck. I'm going to palpate a carotid pulse. And we check how many at a time.
1,
2.
Same
One at a
time.
And then we palpate the trachea. We want to make sure it's midline. And we palpate the thyroid. Should we palpate it? Should we be able to feel it? Go ahead and swallow. Okay, go ahead and swallow. All right, beautiful. So you want to tell me those normal findings, or Ms. Kubiet, or whoever else you are looking at. And we assessed the sternocleidomastoid and the trapezius when we had him. I already had you push against my hand, and I. Okay, beautiful. And that's cranial nerve number 11, the spinal. So then we want to inspect our posterior thorax. We want to look at the AP diameter, make sure we're not barrel chested, that we are a 1-to-3 ratio. And we want to inspect, we would expect the skin. We want to look for any unevenness, any lumps, moles, irregularities, especially on the back. I'm going to do tactile barometer. Go ahead and say 99.
99, 99, 99, 99, 99, 99.
And then I'm going to palpate for CVA. Tenderness, any pain with that?
No.
Costovertebral angle tenderness, it would indicate maybe a kidney infection or something going on with our kidneys. We have not learned that yet. It is in our abdominal assessment. Okay? Then, from the back, we want to start to listen. We looked at symmetry, AP diameter. We looked at chest expansion. There were no masses. We want to listen to the lung fields, and we want to tell what we are hearing. What do we hear on the back? Which ones do we hear on the back?
Vesicular.
Vesicular, and we can hear some bronchiovesicular down the middle. Okay? And while you're doing that, after that or before that, you can percuss. And what would you expect to hear when you percuss?
Resonance.
Over the lungs, they would be more of a resonant sound. Over the shoulder blades, dull, right? Go ahead and deep breathe for me. Out. I'm listening to his bronchiovesicular sounds. Vesicular and more in the bases. And don't forget, we want to hear that lateral assessment, especially on the right side, for our right middle lobe. Okay? So after the posterior thorax, we want to move on to the anterior thorax, and we want to inspect respirations, right? He's breathing. His respirations are even. They're non-labored. He's not using accessory muscles. Their depth is normal. There's no shallow to his respirations or struggling to breathe. And then we want to palpate the chest expansion, look for any masses or tenderness that might hurt, any crepitus. There might be some sub-Q air. We're going to look on the front, and then we're going to listen. Go ahead and breathe in. And breathe out. I'm just noting that it's even. It's even, and there's no palpation tenderness, right? Then I want to listen to his breath sounds. Go ahead and breathe. In and out. Or listen to the bronchial. And deep breath in and out. Good. And good. While I'm here, I'm going to change to the bell of my stethoscope, which this one does not have, but I'm listening for a carotid bruit. You can ask him to hold his breath for a second. No bruits. Go ahead and breathe normal, just normal. I'm going to listen to his heart sounds. I'm listening over the aortic valve, the pulmonic valve. We just want to hear the tricuspid and the mitral. You're more than welcome to say Erb's point if you'd like. And then you find the apical pulse and you palpate it, which is the fifth intercostal space, midclavicular line. You want to look for any heaves or inappropriate movements of the chest. And then you move down to the abdomen. I would move down to the abdomen at that time. All right, so abdomen. We're listening in all four quadrants first. First, we're noting the contour of the abdomen. It's flat abdomen,
Yes.
non-distended, and we're going to go ahead and listen in the right upper quadrant, the left upper quadrant. He would be laying down flat on a table. And he has normal active bowel sounds. And I'm going to palpate light and deep, light and deep. And I'm going to assess for pain, if he's having pain with any of that. Okay. And then I would come to this side, and I would if you were laying on a table, this would be much easier. You kind of pull the spleen, no, you're fine.
Oh.
You kind of pull the spleen forward and palpate down at the same time. And then the liver, you can have a breathe in deep and breathe out. And it's fine. Okay. So that's my abdominal assessment. You can also, with this, you also will need to tell us in the abdomen, listening with your bell, your aortic. We're listening for aortic bruits and renal bruits. And you can listen for a femoral bruit. Because usually it just means, bruits just indicate stenosis or blockage of some sort. Okay? For my belly?
Yeah, you're really hungry, aren't you?
That was impressive, wasn't it?
Yeah.
Okay, so next we're going to look at our upper extremities. We're looking for skin, hair distribution, muscles. Make sure, are they atrophied, are they not? and we want to inspect the skin turgor, and we want to check range of motion. You only have to do this with one arm, but we would want to let him show us abduction, adduction, flexion, extension. Go ahead and put your hands behind your back. Rotate that shoulder and up above your head. Oh, no,
Wait, no,
up above
no.
your head. Behind your head. Good. So we assessed go ahead, let go. We assessed the range of motion within his shoulder. We're rotating it forward and backwards. And there's no pain or crepitus with that movement or limited range of motion. So then we also want to, as we're moving down the extremity, check the cap refill. And we want to look for clubbing. We could put his fingernails together to see if they are clubbed officially. If he would do that for us, which he's not clubbed, we can see the little diamond, like it's good. Can palpate a radial pulse,
Sorry.
an ulnar pulse, and a brachial pulse. And that's pretty much your upper extremities. It says that you have to inspect for clubbing, palpate one radial pulse, inspect capillary refill, active range of motion, and symmetry, skin, hair distribution, and temperature. Then we're going to assess our neurologic function. These are what you will have to do. We have cotton balls over here. Go ahead and close your eyes. I'm testing the trigeminal nerve. You should be able to feel. Do you feel that? Do you feel that?
No. Oh, no. Yeah. Yes.
And remember the three distributions of that trigeminal nerve. You feel that? All right. And then we want to check for stereognosis, where we would put this in his hand. Go ahead and keep your eyes closed. And tell me what this is.
A quarter, some type of
Perfect.
coin. Yeah.
Okay. And then I'm going to do graphesthesia, which is graphesthesia, where I am going to write a number or letter, and he's going to let me know what it is.
7.
Okay, beautiful. Then we're going to check 3 of the 5 deep tendon reflexes. You can choose whichever 5 you want. They don't have to elicit a response. You are just letting us know where they are. Okay? I'm going to do his biceps. I'm going to do his tricep. And I'm going to do his, since I have to do a Babinski, we might as well take the shoe off. Maybe. Yeah, take your shoe off for me. And we can check an Achilles, but first we do remember that swift upbringing to check, or swift flexion to check for that clonus. And I'm going to go ahead and do an Achilles. Okay. And then Babinski's, remember it's just up the foot, and we don't want our feet to flare. We don't want our toes to flare. If they do anything, curling would be our better option. You can do it with your finger, or you can do it with your end of whatever you have. And he has a negative Babinski's. So there's our neurologic assessment. And then we move on to neck and vessels. We already did the, we palpated the precordium for pulsation and heaves. We located the apical pulse. And we verbalized it was at the 5th interpulsal space, right? Mid-clavicular line. We auscultated all 4 cardiac areas with the diaphragm, and in this sense, you must do it with the bell as well. So be sure you're checking why bell hears more high-pitched sounds. And we auscultated for murmurs. This says with the patient leaning forward. And we would rate our murmurs on a scale of what? 0 to 6, or 1 to 6 if they had a murmur. All right, so the only thing we did not check on our neck vessels and heart was a jugular vein for JVD, jugular venous distension. So he would be on his table, kind of slanted, kind of at an angle. We turn the head, check for jugular vein. We could come under the to the liver, give us some pressure, and see if it distends out or if there's any pulsating. A normal finding would be that it is flat, right? We did the abdomen, we inspected the contour, symmetry, skin. We did the bowel sounds. This wants you to start in the right lower quadrant, so try to remember that pattern. And light palpation of all of the quadrants. We checked for aortic and renal and iliac and femoral arteries for bruits. And we percussed, you would percuss the abdomen, and we would expect to find what? Tympany over the stomach, right? And then dull over bowel or anywhere else. And then we want to check our lower extremities. This is where you will finalize. We're looking for symmetry. We're looking for muscular distribution, strength. Go ahead and lift your leg up. Don't let me push it down. Good. Lift this leg up. Don't let me push it down. Pull back under the seat. Pull back under the seat. Bend your leg. Bend your leg. he's flexing his knee, and he's bending. I'm checking his hamstring. This leg too. Good. All right. Heels on the ground. Toes up. Don't let me push him down. Push down on my hands. Okay. His bilateral strength is good. I would check a dorsal pedalis or dorsalis pedis.
Through my shoe?
No,
No.
with the shoes off, not through a shoe. Posterior tib, popliteal, and femoral. I don't even think you have to check all of those. And then I want to check for edema, any vascular changes, hair distribution, and then I want to check range of motion of the knee. So I did flexion and extension. Extend the knee, flex the knee, and his range of motion is superb. So I believe, we didn't do a cap refill on the toes, but you would. So we did the symmetry, skin, hair distribution between toes and heels, which his shoes are on. Palpate one popliteal, one posterior tib, and one dorsalis. They should be 2, right? 2 plus. And he's warm, he has no pretibial edema, and his cap refill was less than 3 seconds, and his active range of motion is spectacular. So that is the head-to-toe assessment that you all will be graded on.
27-24.
I think